So week 8 is amazing. We're almost done. Literally, you have next week I teach, and then week 10 is an exam. And then week 11 is your HESI, and then it's remediation and you're done. So I literally after today have only one more class to teach with all of you. So let me tell you what's going to be going on with that. Now, do know that next week's going to be the reviews again for exam 3. I will be starting to do HESI reviews starting on week 10. I have a couple different ways I do it. Number one, I do one in class. Now, it is 100-question Kahoots. Now, many of you have to leave, go to another class, pick up kids, whatever. I understand that, but I'm going to go on as long as you let me to go. And then, of course, it's going to be the recording on those questions you do miss. And then on Sunday, before the HESI week, I do an open forum question and answer on all the concepts, all the topics I know that are going to be on the HESI, because I get a report. Now, do I know exact questions? No, but I know about where they could be. So I go and we go back and forth, and I'm starting to make you think more. I also think that this question and answer review also helps you to think a lot better, because a lot of you are going into capstone, and in capstone you've got to put all the concepts together and apply them. Okay, you've learned everything, now put all the pieces together. I think between the Kahoots and the way that I teach them and talk over them and make you think, and then that last piece of the puzzle, that question and answer session, get you thinking a lot more, because I do a lot more of student input. Okay, it's just not me talking. I'm going to be asking, so Yesenia, what do you think? Brittany, what do you think? If this happened, Wendy, what do you think? And I'm going to be pulling those pieces together. And if you don't know, you don't know. I mean, come on, nobody knows everything. It is a learning process, and between all of you, you'll learn more. So that's what I'm going to do for HESI. Just to give you some insight on the HESI, my mean average on HESI scores is well over 900. So you do what I tell you to do, you're going to do well in a HESI. And I know HESIs, many of you students struggle with. I know that. Remember, I worked on ground. I've worked with a lot of students for a long time. So I know that usually is the issue. But I'm telling you, with the HESI and the way I prepare you, you're going to be okay. This week, GI, GU, there are a lot of different diagnoses in pediatrics that you don't see in the adult world. Now, there are a couple the same, and I'll be telling you when they're the same. But when you'll see some diagnoses that kids only have, adults don't. So we're going to be doing the PowerPoint, and then we're going to be doing the Kahoots like we normally do. No change. Oh, GI and GU. Now, when you think of GU or genitourinary tract disorders, one of the big things that comes to mind, very simply, is a urinary tract infection. We know urinary tract infections that either boys or girls can get. More common in girls because they have a very short urethra. Also is because little girls like little bubble baths, and they love to have those cute little tight little pants on, and they don't know really how to wipe front to back, and all of these things causes urinary tract infection in little girls. Now, the one thing that we don't think about is uncircumcised males. Now, from birth, we should be taking that infant's foreskin and pulling it back if we decide not to circumcise them. I mean, it's a choice. Either way, it doesn't matter. As long as we keep underneath that foreskin clean, because there can be a collection of this white tissue called schmegma there. And it's like a petri dish. It grows bacteria. And when it grows bacteria, it goes into the urethra and then causes urinary tract infections. So make sure you pull it down. I mean, one of the things with my grandson, my daughter said, Mom, I can't pull it. I'm like, okay, let me try. And for several days I tried. Let me tell you, if I can't get it down, it is too tight. And that's actually called thymosis, Phimosis. And he had to be circumcised because I knew the chances for urinary tract infections. Now, one of the things we have to remember, urinary tract infections, usually they're just in the bladder and they causes a lot of discomfort. You'll see a kid soiling and being incontinent when they're potty trained. They'll have that enuresis or bedwetting at night when they're potty trained, and or that urgency or even redness, or they're holding themselves there. These are all the signs of them. If we get them on antibiotics, we need to make sure that the child finishes all of them, because if they don't, that infection could go right up and hit their kidneys. And now you could go into kidney damage. So make sure as nurses, we say, please, could you finish the whole course of antibiotics? And then you should go back to the doctor, the pediatrician, in order for them to do another culture to make sure it's gone. So like I just said, what are the signs? Incontinence when they're already potty trained. Sometimes it's that smell, and it could be, and you'll know when there's an infection. And what if the kid is always running to the bathroom and holding themselves and running? That could be signs of it too. Now, parents should be taught how to look for these things. What are those signs and symptoms? Teaching the parents, number one, because many of them don't know how to properly write from front to back. And the other thing with adolescents, if you're seeing a lot of urinary tract infections in adolescents, many could be sexually active. And if they are, tell them to urinate as soon after intercourse as possible. That has actually been shown to decrease the amount of infections. So once we have the symptoms, we know there's a urinary tract infection. How do we, examine it, and then how to treat it properly? Well, we're going to do a urine culture and sensitivity. And urine culture sensitivities can be done in many different ways. Now, on infants, I've already told you, the best way to do it is a catheterized specimen, because you're not getting a bag and all of the skin contaminants. So we know that sensitivity, or which medication is going to use from what bacteria, which one will work, it's not going to be the skin, it's going to be urine. And we don't want infants to be keeping this infection in them because of a wrong antibiotic. So we will be rechecking them also. Now, sometimes the infant is too small. We do something called a suprapubic aspiration. We do this with the premature infants. Now, they could be, 600 grams, 750 grams, like a little over a pound. And, they come up with signs of sepsis. Usually it's apnea and bradycardia, and maybe a temperature. So what we'll do is clean the area above the symphysis pubis, and we'll take a needle and put it right in there. And that's right where the bladder is. And they'll take a little urine. Now, usually they're on some sort of sedation, and we'll give them a little extra because you're poking right into the abdomen. But it's a very clean specimen because their urethras are so small, there's no tube that could go in there. So we have to do it that way. Sometimes these infections are up in the kidneys. We could tap right into the kidney. Sometimes we know there's a sediment that's going on inside the bladder. So we'll put a catheter in and wash it out, and we'll look at that stuff. We'll do ultrasounds to look for any structural issues, and we're going to go into that next. And then that child who's in chronic urinary tract infections, they'll do a voiding cystourethropy. And what that is they'll put dye into the bladder. And usually they put a Foley in. It's an outpatient procedure. And they'll put this dye in through the Foley into the bladder. And they'll see if it refluxes up the ureters and maybe into the kidneys. And then they'll hold it for a while and then they'll just let the fluid come out, and they'll see if there's areas where they're stuck, and they'll look for those structural issues. And it could be maybe they have to go in, put a stent, or maybe one side works of the ureters, one doesn't. It answers a lot of questions. IVP is more for your, your kidney stones. We use that more in the adult world. And then, of course, you can do just a renal scan. But, I don't really see them much in the pediatric land. Now, as I said, sometimes we got to go in and go right into the kidney and get a specimen. And sometimes we need to do a renal biopsy to see, how's the tissue? Is it infected? Is the tissue healthy? Now, a lot of the things that we do for renal biopsy is extremely similar to cardiac catheterizations, as in, we make sure that dressing is a pressure dressing. Now, we've just entered a kidney. It could leak urine. It could leak, maybe you went through a blood vessel. It could leak blood. So we want to make sure there's a pressure dressing or a sandbag for older kids there. If we start having abdominal pain, we know that that urine is leaking into the peritoneal cavity because it's caustic, it burns, it causes irritation. And then, of course, we've touched the kidney, we're going to watch intake output. It makes sense to watch that, making sure the kidney's still urinating. Now, after surgery or after this biopsy, make sure that we keep them in bed for 24 hours. Always you're going to do vital signs. That's part of it. We can tell a lot about leaking or bleeding with just their heart rate and their blood pressure. So I'll be watching that. And of course, any of that pain, we'll be looking even closer. So again, renal biopsies usually are done under conscious sedation, but tell the child that it could hurt a little bit. Again, be honest. As I said, sometimes there's some sort of obstruction. It could be one side, two sides, multiple places, one place. It could be that the vesicle, which is called the bladder, the vesicle leaks up into the ureters. So it's a vesicle ureteral reflux, right? Or ureteral vesicle reflux. Something's not going right. And that bladder, the vesicle, the sphincters are not tight and it leaks. And it could go to the kidneys. And we know that the bladder really isn't as sterile as the kidneys because there can be some entrance of something going in there. So as soon as we can find it, correct it, it'll be better for the child because our goal is really to protect those kidneys. And you have this picture in your book also, but it just shows the different names. If it goes into the kidneys, an obstruction, it's a hydronephrosis. Blood can't come down. The urine can't come down into the vesicle. And you could see that stenosis can cause, it also hydronephrosis. We know those sphincters have to work or that leaking can go up and down, and we don't want that. Now, let me say three things before I tell you what nephrotic syndrome is. It has nothing to do with renal failure. The kidneys are not in failure, has nothing to do with renal failure, okay? That's a misnomer that every student wants to put on the syndrome. It is not renal failure. What it is the kidneys say, protein, bleh, I don't like you, I'm going to get rid of you. But the protein comes out in the urine and it looks like beer foam. That's exactly what it looks like when you see this urine come out. Also, protein is in your blood, right? Intravascularly. So you lose all this protein intravascularly. And we know protein or albumin intravascularly has to do with administering drugs. Because if you don't have enough protein, you got to be careful with dosages. You need to give littler dosages or you can become toxic. That's one of the big concerns with nephrotic syndrome. Now, because there's no protein intravascularly, yeah, you worry about drugs, but you become a hypotonic solution and the body don't like it. They want to be isotonic, everything normal, right? So what does it do? It goes interstitially to try to figure out how to make the tissues, the fluid more isotonic. So you're going to see a lot of edema. Usually these children come in with big puffy eyes. That's the first place you see it. You'll see them puffy, and they can get puffy in their mouths. That's why they don't like to eat, because of that puffiness, in their mouth and their tongue. It's all part of that edema that goes on. So what is nephrotic syndrome? Massive protein loss. And that protein is coming from the blood. So remember, there's things that's involved with that. It causes edema. Now, this is an autoimmune type thing where they are at high risk for getting infection. So again, good hand washing, important to teach the child, the parents, and of course, you yourself. As I said, there is a loss of appetite because their mouths swell up with all of this edema. And all that edema, makes it hard to bite and chew. You probably are chewing on your gums in the cheeks, and now they're all broken down and they hurt. So part of the loss of appetite. Now, what do you do for any patient that has too much fluid or interstitial fluid? Well, you want to prevent them from getting more, right? So salt restriction, fluid restriction. And if they're full of fluid, they're not going to be really able to do a lot of activity. So, frequent rest periods, that's what that means. And again, usually there's other kids at home or parents. Let them know that at home, this is a lifelong thing. Fluid restrictions and salt restrictions must be done. Well, how do we manage it? How do we know that all of this has worked, right? Well, we know that all of these restrictions should decrease the amount of fluid in the body. Also, they give steroids as part of decreasing the inflammation in the kidneys, which sometimes it causes fluid retention. But in this case, it actually helps a little bit with it. But this is why, another reason, intake, output, daily weights. Anything with fluids, intake, output, daily weights, all right? So we're going to stop them from excreting their protein. We're going to get all of that edema, get rid of it. We are going to make sure they don't get an infection. And then we're going to be monitoring fluid balance by the way that we know how, our priorities, intake, output, and daily weights. Now, we've talked about rheumatic fever because of a strep throat, right? Well, here's another condition that's caused by a strep throat, or undertreated or a not treated strep throat, acute glomerulonephritis. And it's somewhere up to about 3 weeks after an infection. So first thing we're going to ask, has your child been sick lately? When we see the symptoms of not urinating, swelling up, edema, and your blood pressure goes up with all that extra fluid in you, okay? It's just part of the whole thing. You think kidneys, always think blood pressure, right? You always want to maintain that blood pressure at a good rate. Well, this is the same thing here. So we'll be looking at the urine. A lot of times it's bloody, and we know protein's going to be there if we are suspecting glomerulonephritis. So we're going to treat the strep. It's a longer-term treatment, but we'll treat it. Most of these kids will be fine. And, the oliguria, the edema, hypertension, all will resolve. There are some kids, not many, but a few, that might become chronic. So they have damaged their kidneys. Usually those children have gone on too long. So that kidney damage has gone on too long with this strep infection that the body can't come back from it. So again, treatment. How do we treat this? Daily weights, intake, output, watch the salt, watch the fluids, and keep them from getting infections. And the other thing we do is abdominal girth, because you can swell up into the peritoneal cavity. It's something that is also watched too. Okay, Wilms tumor is a tumor on the kidneys, usually in boys, ages 3 to 5 to 6, usually African American. And in my lifetime, I've seen one. It was a little boy who came over after that earthquake in Haiti about 10 years ago. Our hospital had gone down there, and we found this child. And this kid showed up in my triage room one weekend, because that's what I work Saturday, Sunday, the Baylor shift. And I always worked in the triage. They liked me there. And this kid comes in, and this religious group had picked him up at the airport and was told to bring him to the ER. So they did. His records were all in French, so I couldn't read the records, but I could do an assessment, couldn't I? So I did. I did a set of vital signs. I did some neuro checks. I listened to his lungs. I felt his pulses, and then I checked his abdomen, bowel sounds. And when I got to the left lower quadrant, I felt like a softball-sized hard mass. And I don't know why to this day why I knew what it was, but it was a Wilms tumor. And all of a sudden I went, oh, this is a Wilms tumor. We cannot touch this thing. Now, Wilms tumor can be removed and taken out very easily, okay? It's a curable type of cancer because it is cancerous. But the problem with this is if we manipulate that abdomen too much, we could break off little micro pieces of this tumor into the peritoneal cavity, and it could cause metastasis. So big sign over the bed, big sign on the chart. I'd put it on their forehead if I could. Do not palpate the abdomen. They do not do a biopsy of this, because what would that do? It opens it up and allows the metastasis to go into the peritoneal cavity. All they do is radiation or chemo or both or whatever they like, and then they do surgery. Now, problem with surgery on these children is the kidneys are in back of the body. They're in the back. They have to go through all the intestines to get to the back. So, of course, you're always going to be monitored and taken output because you've touched the kidney. But remember, those intestines have been manipulated in order to wade through them to get there. So look for a child making sure that their bowels are moving, because they can have a paralytic ileus postoperatively. One of the things is paralytic ileus on this, but do not palpate abdomen. Big signs. Now, children can acquire renal failure, or they could be chronic due to other things. Now, acute renal failure is usually due to that obstruction that we didn't fix, or we didn't see, or the parents ignored. And it's mostly, that they didn't get the treatment they needed for whatever reason. It could be medications too. I've actually seen too much ibuprofen in an older patient create renal failure. He was almost to the point of getting dialysis, and he started urinating from ibuprofen. So that you've heard about it in pharmacology and sort of forgot. Well, ibuprofen, if too much is taken, that can occur. And then chronic renal failure has to do with some sort of congenital abnormality. It could be some sort of hereditary, something that went on that can cause it. Renal failure, whether it's an adult, whether it's children, have the same sort of things that occur with it. Those electrolyte imbalances, decreased in urine, the acidosis. One of the big things that can happen with acute renal failure is it can occur because of not medications, not because of, these strictures or structural stuff, but dehydration. Dehydration in children must be treated as soon as we know it. Dehydration will decrease the amount of blood flow going everywhere. And the kidneys is one of those things that let's take the blood away from them, and it can cause the kidneys to be damaged. So dehydration, children, that's always a priority with children, okay? Now, chronic renal failure is when, 50% is gone, your kidneys, only 50% work, and it deteriorates over time to the point of nothing. What can happen? Why is that chronic? Well, I told you it could be due to those refluxes, hereditary, some sort of kidney infections. But if they have some sort of anaphylactic episode to some medications or something, the anaphylactoid purpura goes in, could kill kidneys. And think about lupus. Lupus, the body attacks organs, right? could attack the kidney, and the kidney also could be attacked and damaged. So these are things we look at with children with lupus. So how do we manage these children? Well, it depends on the kid, depends on the ages, but we just want that kidney to function as best as we possibly can get it functioning. Of course, we're worried about intake, output, making sure that those wastes are coming out of that child. And we know any kidney, we worry about potassium, right? Besides other electrolytes. But you always think of kidney failure, you think of elevated potassiums, right? It's just part of what we see. Another thing is because of the erythropoietin and they don't have red blood cells being formed, hemoglobin hematocrits are very, very low. Now, just like you have cancer patients that good cells are being killed, and sickle cell even, that you have really, the cells are dying quickly. Well, they can give erythropoietin. It's a synthetic form, and it's a sub-Q injection, and it can be given to stimulate the body to produce its own cells. And the goal of that is to decrease the amount of blood transfusions, because we know blood transfusions are going to cause problems in the long run. I mean, it could be just that one with this weird antibody in it, and now it's hard to get blood for these kids. So if we can decrease the amount of transfusions, that's the goal of erythropoietin. You know, these kids are stuck 2, 3, 4 times a week, many of the older children on hemodialysis. You know, trying to promote a normal active life is difficult. You know, I did do clinicals. I was a supervisor from another university, and I was put in my hospital, and they put me on the kidney floor. I had floated there once, you know, a long time ago, but I really didn't know that they had a dialysis unit up there. And I had the opportunity to speak with the nurses. And I'm like, well, how do you keep these kids going? Well, many times these kids will come in with homework and the nurses are helping them. Or these kids are making things for other kids to tell them, you know, about dialysis. And I was very impressed that, you know, these kids were actually happy that they were there. It was the nurses who made it an experience that didn't make it like such a chore that they had to come in that many times a week and, you know, miss a lot of that schoolwork and good stuff. Now today, many times first time dialysis is going to be peritoneal dialysis. I had a good friend who at age 64, kidneys started to fail, and they put her on peritoneal dialysis to start with. Now, what is the benefit of peritoneal dialysis versus hemodialysis? Well, number one, infants cannot be on hemodialysis because the flow, the sucking in and pulling in of blood of that dialysis machine, the turbulence is so bad that it'll go up and rupture brain little vessels and cause interventricular hemorrhages, which can cause cognitive delays. So they can't. So we need to use their abdomens. Their peritoneum is going to be their kidney function. You know, I first started in this hospital, I think within 2 weeks, I was taking the peritoneal dialysis course because I wanted to know how to use this machine and how it worked. And it's really not difficult. It's just maintaining sterile field. Why do we want sterile field on these children? You only have one peritoneum, and you want to keep that peritoneum filtering and doing what it needs to do to get rid of the waste products. How is this done? Well, there's a little machine and tubing, and you got the tube sticking out of this kid's abdomen. They put a warming thing on top, so this fluid is warmed, so it's not cold stuff going into these infants. And it's some sort of solution that the nephrologist orders, and they're always different. And we prime the machine, and we hook it up to the end of the tube, just like an IV. But there's like a 3-way valve. So the doctor will say, okay, the infant, put 100 mLs in and let it sit in the abdomen 20 minutes and then drain it for 20 minutes. Each one of these is called a cycle. So put the fluid in, let it sit and drain. It goes into a Foley catheter bag. So we know how much went in and how much came out. The difference at the end of the night, because this is done at nighttime, is the urine output for the day. So it's pretty neat. Now, what are concerns? Well, the biggest concern with peritoneal dialysis is that abdomen. You got one. You've got to really maintain sterility. And if you're seeing a change in that fluid, you're seeing sediment, something, you're seeing a reddened abdomen, anything, you need to call that doctor. And why are you going to call a doctor? You need antibiotics ordered immediately. Now, I had a lot of nurses, on questions regarding this say they're just going to start antibiotics. Well, you need the doctor's order to start antibiotics. There's not just a routine type of antibiotic there. So number one, call the doctor. So again, you call a doctor, change in fluids or that tenderness, and you've got to protect that peritoneum. I've seen one little boy, I was working at a prescribed medical daycare, and this kid had poor kidney function. He had a prune belly, what it's called, and the kidneys didn't work well. And this mother had this child on peritoneal dialysis. The kid would come in every day, and the dressing on this peritoneal dialysis catheter is very well done. Now, I'm very OCD about dressings, making sure they're neat and tidy and everything goes where it should. Well, I think the mother, little Willie, because his name was Willie, she must have taken lessons from me because they were amazing dressings. This kid never got an infection. And at age 3, he got his kidney. So he's doing really well today. So peritoneal dialysis does work, but it takes due diligence with it. So the biggest concern, protect that abdomen, okay? My girlfriend, who was put on it, she one day hooked up the wrong thing to the wrong thing, and she called I don't know, she's an RN, but she did something wrong. Called the office, and she had to run in and get a bunch of IV antibiotics to protect her abdomen. So it is serious, extremely serious. Today, it's years later, but now she's on hemodialysis, but she did have a couple of years of only at nighttime. So they have all day long to be kids, which I love, or with her to be a person, to go grocery shopping, to visit people, go to doctors, whatever she had to do. So what best describes acute glomerular nephritis?
B.
Again, it's like rheumatic fevers after a strep infection. So how do we treat it? Antibiotics. Good. Okay, GI, mouth to anus, everything in between is all considered GI. A lot of crazy stuff that happens in children. And I think your matching worksheet really covers all of those weird diagnoses that many of you probably have never heard. Well, the one thing you wouldn't think about is nutritional disorders, right? But what does the GI tract do? It absorbs vitamins and minerals and, gives it to the body to feed it. Well, sometimes there's reasons why they can't. And all of those things, you don't get proper nutrition, you are going to see that growth failure. Again, why do we do height and weight on every visit that we see a pediatric child? In the doctor's office, urgent cares, ERs, doesn't matter. It's a height and weight, and we're matching them up. They're not growing. What's going on if they should be? And we can catch these things early. And it seems simple, but I'm telling you, height and weight really caught a lot of children and got them corrected quicker so they don't have these cognitive delays and that their growth can go where it should be. I mean, here's some reasons why, but there's a lot more. Metabolics, could be HIV, cancers. We know cystic fibrosis, they're not getting their nutrition, so they are smaller. Sickle cell, and if you're born premature, your GI tract isn't really where it should be. Now, dietary, one of the things that can happen is called celiac disease. All has to do with gluten in the small intestines. And it all has to do with fat ingestion. So these children cannot eat wheat, rye, oat, or barley flour. So this is breads and cakes and muffins and all of these things. Years ago, we had these children and they couldn't eat any of this. And if you're looking for a supplement type of flour, which actually there's rice flour out there, and there's a bunch of other different flours today these children can have, that, these kids really just had to go with what their diets were, which means they never had a sandwich, they never had a cupcake, they never had a cake, right? Think about the grocery store today when you go. I mean, even sometimes when you look at, a bag of chips, it'll say gluten-free. And you're like, okay, that wasn't like that, even 10 years ago. So it's amazing the advances. So with celiac disease, what do you see? Well, they're not absorbing fats. So we have something called steatorrhea. The fat's not absorbed and you lose it. And it includes fat, vitamins too. Okay, so you're losing vitamins. And the one thing about their bowel movements, their stools, they're foamy, pale, and they stink worse than any stool you've ever smelled before. As in, you have a child with celiac disease, wear a mask if you're going to be changing a diaper, because it is pretty, I'm telling you, it's pretty bad. With no fat being absorbed, they get abdominal distension because they all have that gas from that stool. And again, they're not absorbing fat. What is the highest caloric content of any food? Fats, right? So they're not getting that nutrition, those calories. So these kids will be malnourished and they'll be littler children because they're not getting all of their calories that they do need. How do we treat it? Well, give them a cheese omelet with bacon in it and have a glass of milk and have, apples and oranges and a big salad, right? All of those things are great. But again, it has to do with flour. Food allergies, I could be anything. There could be allergies or intolerances. Now, what I have learned with me in particular, I have intolerance. I found this as I started getting to be rheumatoid arthritis, and I didn't know I was there yet. I cannot eat avocados, corn, kiwis, bananas. My abdomen blows up and I get sick, pale, diaphoretic, and feel horrible. I don't eat any of that anymore because it's not worth 3 days is how much I feel bad. So that's the intolerance. There's not an allergic like anaphylactic. There's no rash. It's just, it feels horrible. In small children, you would see that lactose intolerance, where they're having vomiting and diarrhea and abdominal cramping from lactose, and we could change those things. Now, an allergy could be a rash, it could be vomiting, could be diarrhea, could be, that abdominal cramping, and these are things that we should be looking for. I mean, I've seen allergies in foods. Mostly the worst I've ever seen is a peanut. My little Christian is allergic to pistachios and walnuts. If he gets close, takes one little bite, you're going to hear him start and coughing. And my daughter called me up one day. He was blowing up. His tongue was getting big. And I'm like, you take that big Tylenol and tell him to chew on it and get him down now, because they didn't have any liquid there. And he turned it around. He now carries an EpiPen, and he knows if anybody wants to give him food, even candy, does it have nuts? I mean, he's been doing that now for 3 years. Does it have nuts? If it has nuts, he will not eat it. And that's many, many children. I had one kid come in anaphylactic with a nut. And I have to tell you the story because it's something that taught me a lesson. I was eating a peanut like with cranberries and raisin little bar because I was out in triage and I hadn't got to eat yet. I was hungry. It was like 3 in the afternoon. I'd been there since 7 in the morning. And this kid comes in, mother's arm. My kid has had an allergy to peanuts. And I'm like, oh, and I have to run the kid back to the trauma room. I've got peanuts on the breath. I've got peanuts on my hands. This kid just touched somebody's hand and he put it to his face and he went anaphylactic. That's how sensitive it was. So I took alcohol and, those little pump things, I don't know, dumped half a bottle on me, I feel. I quick put a mask on. I had the mother carry him, ran him to the room. I went right to the sink and just washed and washed and washed. Changed my mask, another one, put my gloves on, and got him hooked up to a monitor. My lesson is this: I do not eat peanuts. I'm working with children. I do not carry it in my lunch because it is one of the most severe allergies. So I'm teaching you all that. So you don't go through what I did, because I almost needed a diaper. I was really just scared to death. Anyway, GI dysfunction. When you don't get enough food in, you're going to have growth failure. Sometimes it's just spitting up little by little. But remember, every spit up is a loss of nutrition. It could be, you could have nausea, you have vomiting, diarrhea, constipation, your tummy could hurt, you could have bleeding, jaundice. There are some syndromes that causes dysphagia. Two of them are Pierre-Robin and DeGeorge syndrome. These kids, their mouths, they don't know how to chew properly. They usually, when they get older, outgrow it, but as infants, very difficult for them to even try to eat. They choke and they gag on it. They require speech therapy to really help them through this stuff because of all of that choking and gagging. And we know fever causes dehydration, right? Any kid with a fever, they're losing insensible water loss. And dehydration, children, no good. Why do you think I tell you? You have a kid with a fever, make sure you medicate them. Once the fever's down, they're awake, they're alert, they're running, but they're eating and drinking. I don't care if they eat, as long as they start to drink. Now you're starting to understand why fever, get their fever down, get them drinking. So dehydration, when do you see it? Well, it's when you're losing fluids. I mean, you could have vomiting just from antibiotics, right? Vomiting, diarrhea from antibiotics, and that causes dehydration. So what do? Well, call the doctor, get that antibiotic changed. Now, one of the big ones is cephalexin or Keflex. That stuff creates the most nausea and vomit I've ever seen in children. Not as much as the simple ones, Amoxil or Augmentin or Ciclor or Zithromax, but usually cephalexin, which is usually when you have like wounds on your hands and feet and animal bites and whatnot. So dehydration could be that insensible fluid loss, like with burns or with just a fever. It could be because your kidneys picked up and just started excreting. Again, it's that vomiting, diarrhea, diabetic ketoacidosis causes dehydration. Oh, why do you think we're giving fluid right away? It's twofold. Replace the fluid and dilute that sugar and bring it down. It's a twofold thing. And we know burns, that absolutely causes dehydration. Now, one of the things we have to understand, whether we're working with children or adults, what are signs and symptoms of dehydration? Well, an infant can't tell you they feel bad, but they can show you a lot of things. I've got two great pictures here. And when you look at them, the one on the bottom has a sunken fontanelle. They're just sitting there. It shouldn't look like that. Sitting up, it just should be flat. Now the kid on top, look at the color of that child. He's pale, almost green is what I look at. I mean, around his nose and his ears are pale, but that fontanelle is very sunken. Well, what would I do next if I saw a kid like that? Well, I'm going to listen to a heart rate, and I can guarantee you it's probably really high. Of course, take a blood pressure, it's going to be lower. You're going to see a prolonged capillary refill. You're going to see skin tenting. You're going to see, mom says, the kid hasn't peed since last night. Absolutely normal. Kids hold on to their urine. They don't concentrate, like adults do. They just hold it. And I think the most saddest thing you see with infants when they're crying and dehydrated, there's no tears. You can hear them crying and you look at their eyes and you see the quivering little chin, and there's no tears because there's no extra fluid in this child's body. So what do we need and how do we treat these kids? Well, as you're starting an IV, you're going to be pulling a basic metabolic profile. That metabolic profile will tell you how dehydrated they are. You're going to be looking at the CO2 and the sodium and the potassium and the chlorides and see really where are we? What's the glucose? And many times with vomiting, you're going to have very low blood sugars also. So basic metabolic profile is your priority to look at. You're going to be giving IV fluid replacement. Remember, no dextrose and no potassium should ever be given in a bolus of fluid, okay? Only normal saline, 0.9 normal saline or Ringer's lactate. And in children, I usually see 0.9 normal saline. I think rescue, they always come in, they give in Ringers. That's what they have. Okay, it works as long as it doesn't have sugar in it. And if they're vomiting, of course, some sort of antiemetic should be given to stop it so that we can eventually start introducing some sort of oral electrolyte solution. So once we get the potassium back, you can add some potassium when we start a maintenance IV. Now, measuring intake and output, really important. Urine, stools, you're going to have to guesstimate a lot of sometimes vomiting. I've never gone and measured sweating, but if I had a child profuse sweating, you can still measure it. You could put them in a diaper or some sort of chucks underneath, weigh it first, and then after you take them off and it's wet from sweat, you can weigh it again. And that difference is gram to ml. I mean, like a diaper. If you have a diaper weighing 30 grams and you have a output, in that diaper, you weigh it again, it's 60 grams. We know the difference is 30 grams. That means 30 mLs of urine came out of that child. It's very simple. There's just no even thinking about it. I mean, we can look at their weights again. We see their weights going down or going up. Are they gaining weight or fluid? Are they gaining fluid or losing fluid? Again, weights are so important. And then those fontanelles in infants really tell you a lot. Now, as a kid gets older, it can tell you, and you can see that they're confused. Remember, if you don't have fluids, the body's only going to go to your important organs, okay? So the head gets missed. Therefore, that's why you see these sensory alterations, because the blood's not flowing up to the brain as well as it should. It's not getting the oxygen that it needs, and you will see them getting confused. They're getting confused. This child needs some fluid pretty quickly, especially if you see all the other stuff, the elevated heart rate, the low blood pressure, the decreased urine output, prolonged capillary refills, all of those things. That kid needs fluid pretty quick. And it's going to be even hard to get an IV on them, usually. Now, kids do get diarrhea for all different reasons. How do we manage diarrhea? Well, if a kid has diarrhea and no vomiting, we can give oral rehydration, electrolyte rehydration. Infants, we can give Pedialyte. Older kids with Gatorade, Powerade. It can be given. If it's absolutely severe and now they're getting disoriented, of course, they're going to go to IV to get it in there quicker. But if they're still alert and they're not vomiting, given orally can work out real well. And as we have diarrhea, if we just gave fluids, how is the diarrhea or stool going to become more firm or formed? Not with just liquids. We need to start feeding them. Again, a bland diet, no spice, no fat. They used to call it a brat diet. We don't call it that anymore, but basically those foods work well. Bran, rice, bananas, rice, applesauce toast. Those are great things. Crackers, whatever the kid likes, but we don't really use that name anymore. We tell you to feed the child. Another trick that I learned, this is not in a book, start them on probiotics. If you have a child with diarrhea, it'll firm that stool up and it will stop it quicker also. I had to use that a couple times on my little grandson here. Now, constipation. Kids get constipated. Why do they get constipated? Well, number one, we need to find out why were they constipated, but sometimes it has to do with emotion. Something's going on in the house. Maybe mom and dad are getting divorced. Maybe they had to move. Their best friend moved away. The dog died. Grandma died. I mean, it could be all of this. I'm not doing good at school. Emotion and children are related to their stool or their bowel habits. And I've seen it. So trying to relieve those things can actually help for them to start having their stools. Now, what if you're a brand new infant and you haven't moved your stool in 24 to 36 hours? Something's wrong. You'll see a couple things being checked for. Hirschsprung's disease, we're going to go about that a little bit later in this presentation, but hypothyroidism, no stools. And we know without proper thyroid hormones, children are going to lose cognition. They need it for cognition and growth. Remember, when we talk about thyroid, growth, cognition, children. And we also could have cystic fibrosis. So they'll be doing the sweat test. They'll be checking that blood for T3, T4, TSH, doing an x-ray, making sure it's nothing also physical. And that picture looks exactly like what a meconium stool should look like. And it's sticky and it's gooey and it's green and brown and black. And it's extremely sticky. Now, infants, the smaller kids usually don't have that stress going on, right? The first 6 months, they're just drinking milk. A child who is given formula is more apt to have constipation than a child who is breastfed. Usually breastfed infants have multiple stools a day. It's just part of that, the being of the breast milk. Sometimes it has to do with the formula. If they're tolerating the formula and they're just constipated, we don't ever just say give an enema or give a laxative to any child. That is not first priority. We are going to do something to help them move their bowels. Now, if the kid's less than 6 months, how about 2 spoonfuls of prunes? Sometimes, yeah, they're not going to use it. It's going to be seen in the stool, but guess what? It's going to help them move their bowels. Also, maybe even apple juice is used. So physicians do it very homeopathic, naturally. They don't want to do anything else for young children. Sometimes it's a little rectal temperature, but they don't recommend to do that all the time. They would rather you give something like the apple juice or prunes or something that helps them stool. Now, children do get peptic ulcers. You have these little children that are little worrywarts, and they worry about everything. They worry about mommy, dad, school, the dog, the cat, grandma, grandpa, and they just who they are. And we can treat them in 2 different ways, but we're going to treat them like adults, as in diet, number one. Let's watch their diet. And then, of course, try to reduce their stress if we can, let them talk about it, and then place them on medications if we have to. And they could go through all the gamut of drugs. And of course, they're going to start out with the easiest, the ranitidine or the Pepcid, like they're using today. They're not using ranitidine anymore, although it's still in your book. But Pepcid, famotidine, is used first, and then they could add on the PPIs and Mylantas and all of those things. But they'll start out easy, diet, and then they'll add in the Zantac. And, letting the kids talk about it, they usually do good. I've never seen a kid perf a stomach with an ulcer. I've never seen one. Problems with the liver could be due to many different things. The one thing that we need to know about hepatitis is that how do we take care of these? Well, with any hepatitis, you always wear your gloves, but we wear gloves universally when we're touching them in any way that's going to have any body contents on them, okay? But how do we feed them? Well, what does the liver do? It secretes bile. What does bile do? It digests fat. So if you don't have bile going into the small intestines to dissolve fat, What happens with the fat? You lose it, okay? So vitamins, all those fat vitamins need to be looked at. Also, because you're not digesting fat, when you have fat, it makes your belly blow up and causes abdominal distension. So you need high protein and high carbohydrates to replace those calories that that fat would have cost, okay? So low fat, high protein, high carbohydrates is what we need. So if we're choosing a diet, whichever one has the lowest fat, that is what we're going to have for these kids. Now, I mentioned Hirschsprung's means no stool at birth, constipation in the first 24 to 36 hours after birth. These children have this bowel that is called a congenital aganglionic megacolon. Literally, there's no nerves in this colon. So it doesn't feel it being distended. It doesn't do peristalsis. So food or just even mucus or normal digestive secretions and juices, they can't get through. So it's going to distend. Now, sometimes if you look at the picture up top, you see that little tiny little thing that comes down to the rectum. Sometimes a little bit squirts out like a ribbon. Think about a frosting that you want to do a cake with. You put it in one of those piping things and you squeeze it to put your letters on the cake or something. That's the little tiny little ribbon things you'll see. Very specific to Hirschsprung's disease, ribbon-like stools. How do we treat it? Well, Hirschsprung's has no nerves. The bowel is useless. They have to go in and they have to diagnose it. They'll do a biopsy. They will show that it has no nerves and they'll say, okay, we need to do surgery and remove it. It's doing no good in there. It's just a piece of intestines that it doesn't work. So get rid of it. What they do is the child puts a colostomy on this child. And usually within the first year or even less, they'll reconnect it back up. But initially, most of these children, 99%, will have a colostomy for, the better part of the first year of life, and then they'll close it. These kids usually don't have any problems thereafter. And of course, with these things, we're going to be watching the stools. We'll be teaching the parents, make sure this kid's stooling properly to prevent if there's any sort of stricture going on at the places where they did these anastomoses, taking that piece of intestine out. Appendix, boys, girls, adults, men, women, does it really matter? It's the same signs and the same symptoms. It's the same concerns. It's that rebound tenderness, right lower quadrant, McBurney point, same thing. Now, what we're concerned about is that these children wait too long to come in because many of them are afraid. They don't want to tell their mom they hurt or their dad, or they're afraid of needles. And that's a big thing. It's afraid of needles. And again, that's why I did my dissertation on needles, because I could see kids they're just afraid, like no pinche is what they say in Miami. It's that Spanish, no pinche, I used to hear all the time. And it made me, that's where, this about needles, the needle phobia, and, all of my research that I did on it. Now, if a kid comes in, they're complaining of pain, we'll send them over to the ultrasound and we'll see what's on. We will say, okay, right lower quadrant, NPO. And after the ultrasound, the physician will say, okay, put an IV in, and these kids will get to the OR. Well, what happens if all of a sudden the pain stops? Well, your appendix has burst. Okay, that's the telltale sign where that little piece of appendix at the cecum between the small and large intestines, it burst. And guess what? That intestine is full of this debris, goes in and just attacks the intestines that are in there, and those intestines get angry. So post-operatively, the intestines that are angry must rest. So these kids get an NG tube to keep even those gastric juices from going into the intestines. They are NPO, they're on IV fluids, of course. Now, it's peritonitis, which had happened because all that infection went into the peritoneum. So IV antibiotics is your priority for sure. Now, these kids need good pain control. Don't ever expect a kid to get out of bed, sit in a chair, and do incentive spirometry unless you've given them something for pain. Kids hurt. And sometimes we do forget these things. Another thing that we need to look at also is looking at the wound, the incision area. Remember, that peritoneum was all infected, and we closed it back up. 2 pieces of infected tissue were closed back up. We have to make sure it doesn't dehisce and open up. So we are going to be checking that wound as much as we can. And we're going to be looking at those lab values, looking at those white count, looking at the potassium. We have nasal NG tube sucking out, parts of liquid out of the body. What are those electrolytes? Monitoring that, monitoring the white count, seeing if the antibiotics are working. And everything you do post-op for any patient, cough, deep breathe, ambulate, all that stuff. Absolutely, you're going to have them doing, but make sure you medicate them first. Now, another thing that can happen in your young kids, the youngest one I ever saw was 5 months old, and that was a rarity. Usually they're somewhere 2 to 3 years old. Boy, girl, doesn't matter. Their intestines, it's a long tube, but all of a sudden one side sucks up into the other. And remember, the intestines are full of nerves, right? I just said that with Hirschsprung's. They're full of nerves for peristalsis. So when they suck up into each other, it creates a lot of pain. These kids come in screaming. Usually they're being held in the arms by the parents. Their legs are just spasming. If you touch their abdomen, it's hard. You're like, oh, this kid is intussusception. You can just tell. If they have a diaper on, look at it. It might show a little currant jelly, maybe a little blood streak in there. That's a telltale sign of intussusception. So how do we treat this? Well, if they're still in pain, you send them over to ultrasound, and that will show the intussusception. Many times it will just come out by itself spontaneously. Well, sending them to ultrasound is there's going to be nothing because it already popped out. Sometimes we can send these kids home on just a high fiber diet. Sometimes they're just stuck in there, that swelled up so hard that it's not going to come out by themselves. They do an air enema by the radiologist in radiology, and they squirt air up into the rectum and it pops open the intestines. And radiology does that. It's quite an intense thing to watch. Or they have to go to surgery and get that piece of intestines taken out. I've seen only 1 surgery. I've seen 2 air emboluses in my career, and I've seen quite a few intussusceptions come through. If this kid is fine and it's already, resolved by itself, just teaching the parents that if it, happens again and it's prolonged, to get them in, and then we'll do whatever treatment that needs to be done. But high fiber diets, start getting fiber in them. Now, mecodiverticulum. This is some sort of what I call it a diverticulum, or a little piece of tissue that sticks out, and it's in the small intestines. And that little tissue that pops out has a big blood vessel in it, or capillary, but big. And somehow it rips, and it creates bleeding in the intestines. But with this one, it's painless rectal bleeding. Minimal, like maybe a little bit of umbilicus pain, but minimal. It's just this bleeding that comes out. These need to go and get, this radionuclide study, and they find it because it's a vessel. It's like a radiology type thing. And then they'll go and they'll do surgery, take it out, and these kids do well. IBS, whether it's ulcerative colitis or Crohn's, is it segments or is it all of the parts of the intestines? And this basically, we're going to mostly treat it with diet, prednisone for flare-ups, And these children, some of them end up on infusions, Humira, Enbrel, or other infusions because it is ulcerative colitis. Crohn's is more of an autoimmune thing. So depending on which one it is, but number one, it's always diet, and then we treat flares with some prednisone. Short bowel syndrome. Well, short bowel syndrome is when you have a short bowel. And it's usually because something's happened and they had to cut out a big piece of the bowel. Now, young premature infants are born, and we try to feed them slowly when they're born because we want the GI tract to start working. What happens is the GI tract maybe has a necrotic area, maybe there was some hypoxemia at birth. I don't really know why, but the intestines dies. So when the milk gets there, it irritates it and it creates the belly to swell, and that intestine dies. And if it's dead intestines, it needs to come out. And the name of that is necrotizing enterocolitis, or NEC. You know, with these little premature infants, they do it right at the bedside. You know, and I work night shift a lot, so it's a lot less, it's a little more easy going on the night shift than it is on day shift. And many a surgeon would come in because they'd have to do it pretty quickly to prevent spewing of, necrotic tissue in the peritoneum and cause sepsis. They come in and do it during the night. And they would take that little piece of intestines and put it on top of a towel. And I go, here you are, soup starters. And I used to say, I don't believe you just said that. But it's like usually just a little piece. Now, in one case, little Jessica came in for cardiac surgery. And she was just given a little bit of, she was 6 months old, second stage surgery for a hypoplastic left heart syndrome. She came in, she was still on a ventilator, still sedated, but they gave her a little bit of food. The new research had showed that you need to keep the GI tract working. Well, her GI tract didn't like it. And again, she went into NEC. But when they went to do surgery on her, she lost 58 centimeters of her small intestines. What does the small intestines do? It absorbs all your nutrients, right? So can you imagine the nutritional issues to do with her? That is an absolute short bowel syndrome. She was a triplet. She was the only one who was sick, really severe cardiac. Actually, the day I left the in-house nursing in this ER, she visited me with her other two twins, her brother and sister. Now, she is thinner. She doesn't have, anything. She eats by mouth now. She's a little delayed because of all the episodes, but she knows who I was and gave me a big hug. And I told her I was leaving the hospital, and she's like, I'm gonna miss you. And it was nice to know that a kid with a short bowel syndrome with parents who really worked for the child could do so well. Now, just like this little boy, she had a Broviac. She had hyperalin lipids at night. She had a G-tube. She could eat by mouth, but they would supplement her food in her G-tube. They hit her with all sorts of nutrition, and she did okay. The outcome on her was far beyond whatever anybody ever thought, because we didn't think she was going to make it past 6 months. So I saw her at age 18, so I was pretty happy with her. Sometimes your stomach is born on the outside of the body. Can you imagine that? So the midline doesn't close and your stomach is on the outside. Now, as we get to GU, there is one where the bladder, your urinary bladder, is born on the outside. It's either one or the other, usually not both. I've never seen both. But the stomach born on the outside, again, it works, it's connected. But again, worry about infection, keeping it moist, and then surgeons come and slowly stick it in there, and finally they end up closing it up. And they usually do really well. Again, it's just preventing infection during that time. Hernias. Have you ever taken an umbilical hernia and pushing that little soft little thing in and out? I mean, whenever I see an umbilical hernia, I always have to touch it because I like to squish it in and out. Now, what if you can't squish it in and out and it's hard and it's tender and it's painful? Well, that is an incarcerated or a strangulated hernia, and it's twisted, and it means the blood supply is cut off. It needs to go to surgery now, and they need to close it up and they need to repair that hernia. Sometimes it's in the inguinal area. You see old men with the inguinal hernias. Premature little boys, sometimes, if they're prolonged intubated, you'll see those inguinal hernias. But most of the time, you'll see those little umbilical hernias. And they're really benign, but most parents like to close it because it's cosmetic as they get older. They don't want these big things sticking out and them getting teased. The other hernia that can happen is what we call diaphragmatic hernia. And in that picture there tells the whole story. The diaphragm does not completely go across the whole area between the chest and the abdominal cavity, and the intestines come up and occlude the left lung. The right lung is always there. The left lung will never be a lung again. Try to ventilate that kid at birth. That child is going to be very sick. And then they're going to initially, they just want to get this kid stabilized. And then they'll come in, they'll push down the intestines, they'll put a mesh up. But remember, one lung for life, that other lung is gone. And that will be an extremely ill child. Something that happens during embryonic development are things to do with the intestines and the way that they're formed. Some are in a knot that's more like a volvus, and malrotation when they're wrapped around something. And if it gets too tight, pain's going to occur. Actually, you feel there's a lot up in the left upper quadrant because usually nothing else is there. Just left upper quadrant, and they're younger kids. This is what we would suspect. Again, it's just like the appendix. If it's tight in the intestines, it can explode, cause peritonitis, so it needs surgical repair. Now, all of you were taught in OB that at birth, you take a rectal temp on a newborn because it's an accurate temperature, right? Well, you're also going to take it to see if there's an anus there. Not all children are born with an anus. So it's actually twofold here. Now, there's not many of them, but they do happen. I've seen only one. This child will end up with a colostomy to get rid of, again, all those GI enzymes and acids and juices, right? They can put an anus in, but it's multiple surgeries, and then they have to get it tight enough so it doesn't leak. So it's a long-term care to get many surgeries to get the anus back to where it should be. Sometimes, again, you have the bladder that comes on the outside. Sometimes you have infants that are born to have openings between the bladder and the intestines. I have seen urine come out of the vagina. I've seen urine come out of the intestines, out of the rectum. I have seen it with stool coming out of, the vagina. It's that nurse who actually catches it. You're like wiping them and looking, and you're like, this is coming out of the wrong place. Because, physicians don't sit there and see when they're stooling or urinating all the time. They're there for 15 minutes and gone if you're lucky. Nurses are there 12-hour shifts. We know our kids and we know them inside and out. So it's something that we need to be looking at. Now, vomiting. Children can vomit. A lot of times it's reflux. Remember, if a kid has an acute stage of vomiting, they are losing nutrition and they're losing water, and we worry about dehydration again. And if they're vomiting, you can't give them oral electrolyte because what are they going to do? They're just going to vomit. So again, metabolic profile, let's look at their electrolytes. Get the IV, again, give them fluid, no dextrose, no electrolytes in it, and keep them NPO, give them that something for vomiting, and then later on slowly reintroduce some liquids to them. Usually I start with the older kids, even ages 1, 2, with a little popsicle, because they're slowly getting something and sugar in, right? And kids love a popsicle. Who don't like a popsicle? Injurious materials, as in kids eating things they shouldn't. Now, what have I seen with ingestion? Well, a lot of times it is Flintstone vitamins, because they think they're great. They taste good. I've seen them eat those Tide little pods, not like the adolescents. They don't know what they're doing. The little kids, the adolescents do, and it really creates havoc on them. I've seen them eat acetaminophen, Tylenol, and that's liver toxic. So that's dangerous. I've seen rat poison. And I've seen them eat mommy's or grandma's cardiac meds. I've seen all those things. Those things, depending on what it is, what I do in triage immediately is call poison control. Find out what the most up-to-date treatment is. I write it down for the doctor. They follow it up. Poison control follows back, sees what's going on. If they need admitted, they're admitted. And of course, what are we going to teach the parents? Put the stuff away so the kids can't get a hold of it. Another thing kids do is young kids. Now, these are older homes, from the 50s and 40s, and we have them out there. It's not just like New York City, it's all over the country. The kids like to go up on the windowsills and look out, right? And there's a windowsill there. What do they do when they're teething? They're gnawing on that paint, and they're actually eating it like a pica, right? You have to worry about lead poisoning. And lead poisoning, when you start seeing them vomiting or seeing seizures or something else, these children are going to need some sort of therapy like chelation, whether it is the Dysfunction or an apheresis machine, something, get rid of that iron in their body because it is dangerous. Reflux, many kids have it, you're like, oh, I wish the kid could just not vomit one of these foods. And, your clothes are full, you're always doing laundry, and it's difficult to manage. Now, in reflux, some of the older kids, the signs and symptoms you'll see is that they're coughing and they're complaining of pain. Because what's happening is the food's going up their esophagus and it causes burning. And the coughing is they're inhaling the food into their lungs, mini aspirations. That's why the coughing. How do we treat reflux? Well, just like you treat an adult. You start with Pepcid, add your PPIs, maybe some Mylantas. I mean, you could go on and on with the type of medications you could do. The most drastic procedure, but sometimes has to be done, is what we call a Nissen fundoplication. Now, if you get a G-tube, the doctor will ask you, may I do a Nissen fundoplication? And what it does, it pitches over the top of the stomach into the esophagus so that you cannot vomit anymore, which means you're not going to reflux. So problem solved, the food stays down. In a G-tube, remember, you're dumping a lot of fluid in there. I mean, on adults, you could take 2 cans of stuff, 500 mLs in there, right? You don't want it to come up to aspirate. So Nissen fundoplication, it can't. So it is a great thing for preventative in G-tubes, gastrostomy tubes, and it's also treatment, the most drastic or surgical for GERD and younger kids. Now, hypertrophic pyloric stenosis, these are kids aged 3 weeks to about 3 months old. And what happens is the pyloric sphincter, which is right there at the end of the stomach, right before it goes into the small bowel, it becomes thick and it becomes very small. And even just milk, breast milk, can't get through. And what happens is the stomach just fills up, and all of a sudden this kid vomits. Have you ever seen the movie The Exorcist? It's an old movie where across the room, you could take this little 1-month-old baby and point it at a garbage can, and they're going to hit it 10 feet away. I mean, that's how forceful it comes out of these kids. Well, get a kid in who's vomiting. My first question, is it dribbling or is it coming out? Now, if it's coming out, the first thing I'll tell them, stop feeding the kid. These kids are hungry. They haven't gotten food. They eat, but it's out. So they're not getting any into their body. So they're starving, okay? The next thing I'm going to do is put my hand underneath their xiphoid process, right where your stomach would be, and you will feel like a little marble or olive. That's the thickened pyloric valve. You can actually feel it. They go to the ultrasound, they get diagnosed. You start again, NPO, start an IV, and get these kids up to the OR. Postoperatively, they start out, if you're on breast milk, they'll start out with smaller amounts of breast milk. If you're on formula, they might start out with Pedialyte because it's thinner fluid. And then they'll into the regular diet of milk and they're sent home. No long-term effects with these children, so they come out good. Cleft lip. This is either one side, two sides, or it could be also the palate inside. Remember, kids explore the world through their mouth. How do they eat as an infant? They suck, right? So now you got problems. Now, we don't fix it till about 2 to 3 months old. They're a little bit older, so we can approximate the edges of the lip so they're not a crooked lip, okay? After surgery, you put this Logan bar, that metal thing there, so when they try to smush their face into the crib or the floor, it's not going to open up their lip. And it does work really well. And your book has this picture too, all the sort of pictures of it. Now, sometimes it's the palate. I saw a little boy who only had palate. If you don't have a palate, it goes up into your nose. It goes through the sinuses through your nose, okay? These are usually done before a year old because if you don't fix it earlier than that, later, if you fix it later than then, it'll have a profound effect on speech. Have you ever met anybody who's had a severe cleft lip at a young age and palate and wasn't repaired quickly? They talk something like this. I worked with a nurse who had that as a child, and her speech definitely is affected. Now, that's why we try to get them done between 6 to 12 months. They take a little piece of the rib or something, put it in there, and they do really well, and they come around fine. And again, that was a kid with Pierre Robin, who I saw that on. They've got this bottle invented by a mother. Has a soft top. You turn over the bottle, and it fills up that little long piece. And as you squirt a little bit in their mouth, so they still get the feeling of sucking and swallowing and breathing. Now, if you're breastfeeding, you have to like squirt and squish your breast to get that milk in there. And some parents do it because they want to have that breast and that tenderness and closeness with their child. Esophageal or tracheoesophageal fistula. When you think of an atrasia, esophageal atrasia, we think of something that's A without. That means there's no connection between the mouth and the esophagus. It goes nowhere. There's no stomach connection. It just sits there. When you have a fistula, it's an opening. And where's that opening? Between the trachea and the esophagus. So if you ate, what happens? It either goes down the esophagus, comes up and goes into your lung and you're aspirating. Or if it's the TEF, you drink, it goes down the esophagus, across the fistula, into your lungs, and you're aspirating. These children get nothing to eat. Furthermore, you're going to be making sure you're going to get that mouth suctioned out. You're going to have suction at the bedside, head of the bed elevated. They can still hold these children, all of those things, but they are going to have this choking, sputtering, maybe cyanotic spells at birth, which are going to hint you into something's not right, because that choking, coughing is aspirations of their own mucus from their mouth, their own saliva, okay? So how do we treat these things? Well, as I said, you still got mucus going on there. They're still going to swallow. It's still going to go into their lungs. So NPO with an IV with antibiotics because you're having mini aspirations. They do surgical repairs. These kids are normal kids. They just have the wrong connections going on up there. There's no delays, no cognitive nothing. Normal children. Some are done at birth, some are done a little bit later. It depends on the child. So a lot of stuff, huh? A lot of things you've never heard of. I hope my stories help you remember these things, because this is the way that I remember, what these kids look like. I remember the kids, especially my little Jessica, my little triplet. I watched the Miami Dolphins win the Super Bowl with her father one night, and with Jessica, who was very sick in the ICU, and we were screaming and yelling at 12 o'clock at night. Anyway, let's go ahead and do our cahoots. Who's going to win today? Anybody want to win? There's like 50 of them, but they really cover everything. Remember, your cahoots are good for exams and they're good for your HESIs too. So when we get to the point of HESIs, I'm going to be listing all your cahoots in one place. I'm going to give you all of those review PowerPoints all in one place. And you have my YouTube channel. You can go back to listen to any review you want. So you're going to have all of it to help you get your best grade on your HESI you've ever had. How does that sound? Let's get going. Week 8, GIGU. Oh, excuse me. It's a lot of multi-selects. All the following are symptoms of dehydration in an infant. Dry, pale skin, weak lethargy, loss of elasticity, sunken fontanelles, elevated heart rate, decreased blood pressure. I mean, you can see all of these things with these children. What is priority treatment for a child with dehydration due to profuse vomiting? So if a kid is vomiting, how are we going to prevent dehydration? I mean, we already got some dehydration going on. If they continue to vomit, it's going to get worse. And remember, dehydration can cause things like acute renal failure, and we don't want to do that. So we're going to be giving IV fluids. The kid can't eat or drink right now. Yes, there'll be NPO, but your priority is IV fluids. What is a treatment for an infant with diarrhea lasting for 4 days? We know treatment always is going to depending on patient condition, but if they're having diarrhea, go ahead, give them oral sort of supplements. Kids always want to eat, no matter if they're sick or not, unless they have a fever. And maybe IV fluids, but diarrhea treatment is that oral electrolyte, or Pedialyte in this case. What acid-base imbalance might you see with a child who's having profuse diarrhea? Well, there is vomiting and there's diarrhea. Now, you do have like 4 acid-based questions you're going to see on your HESI, okay? So I'm going to be giving you these. I did one last week. We're going to do one this week. If you're having diarrhea, you're losing all of your alkaline because that's all your enzymes. So if you lose alkaline, you're only left with acid. So it's metabolic acidosis. Now, if you're vomiting, you're losing all your gastric acid. So all you're left with is alkaline. So that'd be metabolic alkalosis. That's why they are what they are if you don't understand that. A multi. If an infant's not past meconium stool in the first 24 to 36 hours, what would you assess for? We're going to look for the thyroid, cystic fibrosis, and Hirschsprung's. We're not losing fluid, so electrolyte imbalance, no, that has nothing to do with it. But those three conditions we will. X-rays, and we'll do thyroid tests, and we'll be doing a sweat test for sure. Deficiency of vitamin D causes. Remember, vitamin D is good for tendons and muscles and bones. I'll never forget from, I think, high school, they said that the people on years ago in the boats used to carry oranges to prevent scurvy. It's the only reason why I remember scurvy, but rickets, just think about rickets is with the bones, okay? Your bones crack when you get up, a ricket. That's how I remember. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So patient condition, unable to drink or eat anything. That gives you your answer. And always remember that basic metabolic profile. We want to know how severe it is and we want to know what we need to correct. Very good. Told you a lot of multis. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? I mean, if the kid didn't have a ruptured one, we'd medicate them for pain, get them out of bed, cough, deep breathe, and start to feed them. But a kid with a ruptured, our biggest concern is infection. So NG tube to get rid of all that extra secretion because those intestines are angry. Antibiotics, and again, that surgical site. It was too bad already contaminated tissues put together. It could dehiss, and I've seen them dehiss. Complete bed rest? Absolutely not. Get them up, get them out of bed. You do all those things you do to prevent complications. Passage of urine, usually at night, with children who should have voluntary bladder control. And it's called enuresis. Now, while I'm right here, let me tell you what epispadias and hypospadias is. Boys are born with urethra that the tip comes out the end of the penis, right? Well, in hypospadias is the dorsal. It's underneath. It doesn't go. There's no tube that goes to the end. It comes out the bottom. Epispadias is the ventral up top. That's where it comes out of. These children cannot be circumcised. We need that skin for plastic closure. And then post-operatively, what do? Well, they put a tube in there to hold the lumen open post-operatively for about 7 to 10 days. All we do with that tube is keep it in the diaper so that we don't get urine everywhere. And that's the treatment. And they splay the penis open. It's a general anesthesia thing. It's a big surgery. We want to do it before they go into being potty trained. So before they're potty trained, those must be done. A multi. What is Hirschsprung's disease? Well, we know Hirschsprung's disease. We might see ribbon-like stools because this little tiny little thing that squirts out. We know it's an outpatching. We know that they're going to end up with a colostomy for a while. But it's a congenital absence of the parasympathetic ganglion. That just means no nerve cells are there. So there's no peristalsis, there's nothing. And the other name for it is called congenital aganglionic megacolon. It's just full up. Another multi. When teaching parents about Hirschsprung's disease, the nurse would include what? No, you as being bedside nurses, and I know some of you want to go into the newborn ICU. And what if you have a kid just diagnosed with that? The parents are going to be asking you everything. No, you don't have to know everything about everything. I mean, if you don't know, ask or look it up. But Hirschsprung's disease, there's no peristalsis. It can cause a bowel obstruction. That we are going to have to monitor those bowel habits after surgery. And it is two-stage. Put a colostomy up, let it heal, and then we will reconnect it later. We never, ever, at all last resorts, use laxative or enemas with children. We'll use an enema if they're constipated and we want to just, take it out once, but we don't do that on a daily or weekly or monthly. There should be no routines with those. What type of stools would an infant with Hirschsprung's disease have? Remember, it's that tiny little thing. It's like that little icing thing, ribbon shaped. Very good. Which is the condition that occurs mainly in children when the intestines telescope into itself. It sucks it in. And we know sometimes it comes out by itself. Treatment would just be high fiber if it's going to come out by itself. Or it could be a radiological procedure or even surgery. And it's called intussusception. What would you see in the diaper of a child with intussusception when it's closed up? You're going to see that currant jelly looking stuff with maybe little flecks of blood in it. And that's exactly what you see. GERD. What's GERD? GERD is when the stomach contents comes up. Remember, older kids are going to cough. They're having many aspirations and it burns, so it hurts. Again, remember that big thing that can give surgically can help that is that Nissan fundoplication, like what we use with gastrostomy tubes to keep the food down. Inflammatory bowel disease involves what? So when you're talking about inflammatory bowel disease, it's anything that has to do with intestines, right? They call it actually mouth to anus, IBS. It has to do with all of the above. What would the nurse be looking for when a patient has Meckel diverticulum? Remember, this is something that needs to be diagnosed, and then surgery is the way we fix it. It's in the small intestines. And it's because it's painless, which will tell us that little hint what's going on. A 6-year-old child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? Like, what's going to be your question that you need to ask? What's the number one question? It's going to clue you into what's going on here. I mean, where is the pain? Is it rhiloid quadrant? Is it appendix? Or is it, epigastric? More like, it's stomach, like GI something. So where is it? Abdominal pain. Tell me where it is. What would the nurse expect to see in an infant with biliary atresia? Well, remember, biliary is liver. Atresia is the absence of an opening between the liver and the common bile duct. That means no bile is going into the body. So the bile's building up in the body there. Now, because bile doesn't go down, you're going to see the stool is going to be clay colored. And because of the fat that's not being digested, the belly gets distended, okay? And then, of course, eventually you're going to see the jaundice on these children. Make sense to you now? What structure of the mouth can be impacted by cleft lip and palate? I mean, if you look at that baby and that boy and the beautiful closure, I mean, they really do a good job, really good plastic closures with those sort of conditions today. Cleft lip repair is typically done when? Because remember, they want to put their lip around the bottle and they want to suck, swallow, breathe because, you know, self-soothing mouth, they try to get it done quick, 2 to 3 months. Earlier than that, the kid's too small. They want to make sure that their approximating edge is good. And when does cleft palate repair usually occur? And remember, we try to get this repaired because of speech problems. We don't want to have a child, you know, unable to pronunciate words because they don't have a palate there. And it's usually between 6 to 12 months. Esophageal atresia, A without. Whenever you see atresia, think A without. Remember, stenosis, osis means a narrowing of an opening. So there's no connection between the esophagus, the mouth, the esophagus, and the stomach. It's not there. Remember, NPO, these kids are going to be choking and spittering because all of that stuff's going to come up and go into the lungs, and they're going to be aspirating. What are the classic signs of esophageal atresia and tracheal esophageal fistula? So no opening to the stomach and an opening between the lungs and the esophagus. Everything's going right to aspiration. Olive-shaped mass, right upper quadrant, is pyloric stenosis. Current jelly abdominal pain is intussusception, okay? So I gave you that matching sheet. Keep you straight. Neonate with suspected tracheal esophageal fistula. Nursing care should include what? Elevate the head of the bed. Nothing by mouth. Remember, you feed it, it goes directly into the lungs. And because it's going directly in the lungs, we're not going to feed them. You need an IV fluid and then antibiotics for those mini aspirations of just on their own saliva. 5-year-old complains of epigastric pain and a persistent cough. What would you suspect? And that's your gastroesophageal reflux. I mean, an ulcer, you'd have the pain, but you're not going to have that cough. That cough is those aspirations. It's going up, refluxing up, it's going into the lungs, aspirating. Why is ranitidine used for a child with peptic ulcer disease? What does ranitidine do? What is the goal of ranitidine? Or Pepsid, famotidine, famotidine. It basically just reduces gastric acid, and hopefully that will help the stomach to heal. That with a good diet should work. Signs and symptoms of a hypertrophic pyloric stenosis. Pyloric stenosis is projectile vomiting, and you'll be able to feel that pyloric valve. It's like a little olive or a little marble right in the right above, underneath the xiphoid process, right upper quadrant, left upper quadrant, right upper quadrant. So signs and symptoms of pyloric stenosis. So remember, when a little infant comes in 3 weeks to 3 months old, and the mother says they're vomiting, I ask one question: does it dribble or does it go across the room and let me aim the kid at the garbage can, right? And that's called projectile vomiting. Preoperative treatment of pyloric stenosis include so we don't want them to eat anymore. They could aspirate on it. So NPO, start an IV, and of course, give them a non-nutritive sucker so they can satisfy that sucking need. What does the celiac disease affect? Where in the body? And it's the small intestines. Very good. If you have celiac disease, what should you eliminate from the diet? Wheat, rye, barley, oats. You can have rice, but none of those other flours because it will cause severe pain. A multi-select. Vitamins that children with celiac disease are prone to lose are, remember, they have these frothy, smelly stools called steatorrhea. And what is steatorrhea? So if you have steatorrhea, what vitamins go with that? And vitamin C is a water soluble. Fat soluble are A, D, and K. What foods would you select for a child with celiac disease? So when you're checking food choices, anything with bread doesn't work. Anything that uses flour doesn't work. So a bacon omelet, a banana, glass of milk, fine. You have toast, you have macaroni, you've got breaded fish sticks, and you've got garlic bread. All are not good. Phimosis. That was my grandson, why he had to have a circumcision. So it's tight and it won't pull down, and it needs to so we can keep it clean. What is a hydrocele? You know, I always put a couple questions on those areas that I can't cover everything in lecture, and this is one of them. Usually this kid might have a period of incontinence when they're potty trained, and maybe some slight pain in a testicle, but it's a little bit of fluid, and they treat it with antibiotics, and they're fine with it. It heals up by itself. What is a cryptorchidism? You like my monkey picture? I mean, you could tell his testicles. I mean, I thought it was a great picture. Why do you think you go to the pediatrician? One of the first things they do on male infants is check the testicles. Remember, in order to check testicles on a male, it should be warm. If you put them in a cold room, they suck up, okay? But if it's warm, they'll dangle. So that's how we would feel for those testicles. Testicles don't like to be in the heat of the abdomen. They like to be on the outside. Again, you suspect an infant with cryptorchidism. How would you examine this infant? You pick them up and you shake down the testicle, right? Put them in a warm room, okay? Because they'll sag and they'll come down as far as they can. And that's an accurate examination, not in a cold room. A hypospadias. Remember, males should have their urethral opening on the tip of their penis. They can be underneath or they can be on top. You just have to remember what anatomical term that was, right? And it's the ventral side. It's not the dorsal side, it's epispadias. That was just a check in your terms. A multi. How is a hypospadias corrected? On the HESI review, I have a PowerPoint. You're going to see a splay of what they do to a penis. It's quite graphic. So they use the foreskin, they put that stent in there, and they don't do that under local, my dears. This is general anesthesia. They cut that penis in half and open it up, literally. And then they use the foreskin to help with pieces that they need to keep it open. And that stent will keep that lumen open so they can pee out of the end of their penis. What is bladder exstrophy? It's like a gastroschisis. And remember, even though they're born like that, everything works. So the bladder's on the open because the midline didn't close and they're born like that. Again, our concern is to keep the integrity of the skin and to keep that infection free so that the urologist, neurosurgeon can come and get that stuck back in as soon as we make room for it in there. What is the priority nursing care for an infant with bladder exstrophy? So it's the tissue integrity of underneath it and around it. We want to make sure that bladder keeps moist and infection free. This is all about the tissue preservation. What are the clinical manifestations of nephrotic syndrome? If anybody says renal failure, I'll bop you. It's not renal failure. So it's low protein, and you're also going to see that peripheral edema. Again, nephrotic syndrome is all about protein loss. So children with nephrotic syndrome are often given what medications for fluid overload? So remember, nephrotic syndrome is when you lose your protein. So you've got to replace the protein. But you need to get something to get that fluid off too. So what makes the most sense here? We'll give the protein, which is the albumin, we'll follow it with furosemide, and we'll get them urinating. What is used to treat nephrotic syndrome in children? This medication's INO and daily weights and salt restrictions and fluid restrictions. And be careful with infections with these children. It's prednisone. A child's admitted with acute glomerulonephritis. What recent illness could validate this finding? So again, glomerulonephritis is like rheumatic fever. It's a strep infection that has not been treated. So we're going to treat acute glomerulonephritis with an antibiotic. What is a priority nursing care of a child with nephrotic syndrome? So daily weights, the most important thing that we can do. Intake, output, daily weights, fluid restrictions, salt restrictions, and of course, washing your hands. Why is erythropoietin used in chronic renal kidney failure? Because erythropoietin increases the production of red blood cells and decreases how many times you need to give blood transfusions. Another multi. Children with chronic kidney disease can have renal osteodystrophy. What can do this to the child? What happens? Renal osteodystrophy. You think of osteo, you think of bones. Dystrophy is formed not right. So skeletal abnormalities, growth, because they're not going to be growing the way they should. And it all has to do with calcium also. Uric acid has nothing to do with the osteodystrophy in this. So we're going to be monitoring the calcium with these children to make sure that they're not too much. A diagnostic finding of acute glomerulonephritis may be, I mean, what if you have a kid that was with, their father the last month? You don't know what went on. Did they have a sore throat? Oh, I don't know. The kid doesn't remember. What can you do? What tests can you do to prove the acute glomerulonephritis was due to this? And it's a positive ASO titer. If you look at that, anti-strep. So listen, this is something that you will see when you've had a recent strep infection. Okay, ASO titer. Which complication of peritoneal dialysis is most important to prevent? Remember, peritoneal dialysis, what do we need to protect during all of this? Because without this, you don't have a kidney, because that's working for your kidney. And that's abdominal peritonitis. And that could be a change in the fluid color. It could be a temp on the kid or redness of the abdomen. Call the doctor, right? Which clinical assessment is most important to report with a child diagnosed with acute kidney trauma? I had a kid come into the ER, was playing hide and seek or something with a bunch of kids. And he ran around the corner of this trailer and he was going backwards, and the back of his back hit the hitch really hard. Came in with a huge ecchymotic area. Now, they did blood tests. His potassium was 7.6. They were worried about a fractured kidney. So whenever you think of kidney, always think potassium, right? Always go hand in hand. Multi. What should the nurse anticipate for a child who just had a renal biopsy? So you're working with kidneys, intake, output. Of course, you don't want it leaking. You can look at that dressing, and they need to be on bed rest 24 hours so that the kidney can't open up and leak urine into the abdomen or blood or whatever. No ambulation, cardiac cath, or renal biopsy. Bed 24 hours. What would you do if the fluid draining from peritoneal dialysis has changed color and is now cloudy? Call the doctor. Call the doctor, and he will order your antibiotics and get those antibiotics. Your peritoneum is your kidney. You need the kidney to filter all of that waste out of the body. You need to protect it. Call the doctor as soon as you can and get antibiotics started quickly. What would the nurse provide to an infant that cannot eat normally? That kid with esophageal atresia or tracheoesophageal fistula can't eat. So what are we going to do for them? We're going to give them a pacifier, normal growth development. How do infants self-soothe with their mouth? We're going to give them a pacifier. Number 3, Whitney. Good job, Brittany. Whoop, 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 whoop. Number 2, Gianna. Good job, Gianna. Number 1, Mayona. Good job, Mayona. And Elise and Olivia. Good job, guys. Well, that was a good one. Okay, go to your modules. I believe those people here from Monday class, I believe all of yours have been opened. You may start your quizzes when you are done. You may leave for the day. If you need anything, let me know. And I will wait over class for that one student that I'm going to meet with, and they know who they are. I don't think there's any surprises on that quiz. You've heard it all. Good luck, guys. Hey, Kayla, you with me?
Hey, I'm here.
There you are. So you wanted to go over your exam. Thank you for your patience. I appreciate
No
it.
worries.
You know, I had on Saturday, I was having some issues, and I actually had met to make sure with the other team of pediatrics to get those exam grades up. And then moment of unclarity, you know, things were going on. And then, oh, anyway, so thank you for your patience. I appreciate it. I really do.
No worries. I sat there, because I'm an hour behind you. So I put an alarm on my phone because I didn't want to miss it. So I was like sitting there on the Zoom and I was like, "Did she forget about me?" And then I texted you and I was like, I think she forgot about me. So about like 1:30, 2 your time, I was like, all right, I'm just gonna go.
I apologize.
It's
I
okay.
really do. You know how many times I sit on Zoom for a half an hour wait? So I know
Oh,
exactly
I
what you
bet.
did. I'm sorry.
No, it's okay. I was so
Okay.
upset with my test grade because there was so many questions, like even while I was taking the test, that after I answered, I was like, oh my gosh, I second guessed. I know the answer to that and I second guessed it.
Head to toe assessment on a child. What's the most important to consider before beginning the examination? Well, the kid had nausea and vomiting. Vomiting, let me see. Nausea and vomiting, that's a distractor. Any kid you want to go examine, number one, what do? You get on their developmental level. You
Did I
wanted
not
to
put that?
give them, no, medication to ease the nausea.
Oh, okay.
You second guessed there.
Yeah. God, and
Best
how many
approach
times
to
did he
pain
answer?
management. Best approach, again, remember, use distraction with it. You
What
wanted to
did
get it early. You can't give medicine early. That's against the doctor's order.
okay.
So distraction, give them a video game, give them coloring, give them stickers, play a game with them, put music on, do something, and they forget. Children do so great with distraction.
Okay.
Everything can be going on, and you give them a Princess Belle sticker, and they're like, oh, Princess Belle, or Frozen, whatever. They go bonkers, and
Okay.
they really do. All right. Respiratory syncytial virus. The infant has a history of prematurity and low birth weight. Which statement by the parents indicates the teaching was successful?
That was that medication one, right?
Obviously,
Yeah, I kept thinking of I guess it's the generic name.
this
I kept
images.
thinking, yes, I kept thinking of that and I was like, wait a minute, isn't that what the same thing? And that one yeah, I knew that one.
Okay. So this was a tricky question. Which of the following will a nurse anticipate being included in the plan of care diagnosed with cystic fibrosis? They're diagnosed already. You put the sweat test, but it's chest
That's
physiotherapy.
before. Okay.
They're already diagnosed.
To use the sweat test, that would be before, right?
That's how you diagnose cystic
Yeah,
fibrosis.
okay. Okay.
Remember, you can lick their skin and taste salt. You
Yep.
really can. All right, the enzymes for cystic fibrosis. You got them all right, except if taking the capsule form, a whole capsule, or you can open the capsule to sprinkle it on the food. Because some
You
young
can do
kids,
that?
oh yes, just like the
Okay.
powder, same thing. You can, absolutely. Powder, you must rinse your mouth. But the
Mhm.
capsules are little tiny, they're, you know, they go down. But yeah, you can
Okay.
sprinkle them on the food. This is another one of those questions, tricky. The nurse is caring for a toddler with acute otitis media. They have a fever, they're irritable, pulling at the ear, and they've got that purulent ear discharge drainage. Based on these assessment findings, what is the priority nursing diagnosis? You put risk for infection. They already have it.
Yep.
It's the pain.
Okay. I knew that one. These I overlooked all of these.
Chest tubes being removed. You didn't medicate for pain before they took them out. Remember I emphasized how it burns and hurts bad? I even have talking to adult open hearts. Remember, I've done adults and children, and I've done adult open hearts. And when they pull those chest tubes out, it hurts and burns. That's their description. It's like for maybe a half a minute, it's intolerable. And then it goes away. So medicate for pain first. You did everything else right. Cystic fibrosis and becoming pregnant. I told you that girls could get pregnant, but there would be, high risk with it. Males can't because their vas deferens doesn't work. So it was a bilateral lung transplant. 1 year later, they could get pregnant.
And I
So
put the one where the woman wasn't sterile, right?
infertile, yeah.
Yeah, that was I knew that. It was males. Hoy.
Iron deficiency anemia, priority nursing diagnosis. And you put nutritional deficit related to poor dietary intake. But iron deficient anemia is all about the energy, lack of energy. So it's fatigue related to decreased oxygen carrying capacity of the blood due to poor nutrition.
Okay.
So it was the other one. And then you mixed up Hodgkin's and non-Hodgkin's. Remember, Hodgkin's is only from the shoulders up and big type of non-tender lymph nodes. Non-Hodgkin's is diffuse all over the place. So it asked for diffuse lymph nodes, which was the non-Hodgkin's.
Okay. And I put Hodgkin's.
Uh,
Okay.
and then there was one math question which asked the dose per day, not per dose.
Oh my gosh. I've
Remember
been
I
doing so
told you?
good on my math.
Remember I told in front of the class before you started, make sure that when you get the answer and when you do your math, go back and make sure you look to see what they're asking for. I was
Yeah.
trying, hey, and one's gonna be, but I couldn't
Yeah,
say that. So
Okay.
you're fine, you're gonna make it there. Exam 3, again, it's a lot of diagnoses, a lot of systems are covered. Go to review. If you need help, you're not understanding anything, we can meet also before
Okay.
your exam. We're going to get you through. And I've got a plan for HESI coming up, like I've told you all. We're going to be doing some more on week 10. And usually on Sunday, before HESI starts, I do that question answer, which really puts the light bulbs on for many, many students. I've had students go to it at that borderline, like needed a good grade. I needed an 80 something, and they did it because they started to think. And I know that goes into capstone as you get there, because you're learning all this stuff, and now it's applying it to all different things, which is really hard. So that's why I try to talk to you over Kahoots. Look at the question. What is it looking for? What do I know? What does that mean? I try every week to reemphasize that. So that question and answer, please come to that one too for your HESI, and you'll get a 900 something.
Do you know when yet that will be?
Your HESI is week 11. Your campus is the one. Which campus are you from?
Pensacola.
All right, you're going to be on campus, so they should be posting that pretty soon.
Okay.
They usually, Pensacola tries to keep where your classes are. They try to keep you there at about the same times.
Okay.
Okay.
Okay, thank you so much.
No, you're welcome. We'll get you there. Just ask
Thank
for
you.
help. If you don't get it, I'll promise I'll be there next time.
Thank you.
My daughter just got home from a 21-day vacation of her dreams all over Europe, and she had this big type of, she was in Dubai as president of the Young Realtors of South Florida. She's now
Oh,
president.
wow.
And
Oh my
free
gosh.
trip over there. Then she went to Barcelona. She went to Turkey. She went to Italy.
Oh my gosh, that's
And she had the
amazing.
money to do it. She's
Good
doing
for
so
her.
well in her life. Yeah. She's a
That's
realtor.
awesome.
Yeah.
Wow.
So she, I'm like,
Yeah.
so my mind was all over. And I do
I
apologize
understand.
again.
No worries. I appreciate you meeting with me now.
No, thank you for coming. All right,
Alrighty,
we'll
I'll see
get
you
you
next
through.
week.
Let me know what you
Okay.
need. Bye-bye.
Okay, thank you. Bye.